Then we'll hear a little bit more about multimorbidity, what it is, by Ivan Boutmans, and then we will hear later from an introduction to population health management by Jose Cerezo, followed by some examples of England and Portugal as well on how to manage multimorbidity and how to use data for that. And later we want to hear from you as well. So I will be joined by Sultan, the Vice President of the Healthy Aging section, to moderate a discussion where we hope to hear from you some examples of how you are preventing multimorbidity, but also how you're managing it in your communities, and hear more about the efforts from WHO Europe in a new strategy that we are developing and how you can participate. So without further ado, I hand over to Charlotte, who is in a very exciting place over there in Brussels. Charlotte? We can't hear you, Charlotte. I think Charlotte is frozen, actually. Monica, yeah. Maybe you can try to connect with Charlotte. In the meantime, then, Natasha, may I please invite you to open?
Absolutely, until perhaps Charlotte overcomes her technical issues. And I hope that you can all hear me. What can I say? It's always a pleasure to have the opportunity to be present virtually at one of these events of the European Public Health Week. Of course, in my previous capacity as EUPHA president, I can still remember the internal debates about when we decided to hold the first edition. And it gives me deep satisfaction to see that this has just continued to grow from year to year. But today we have a very important topic, and thank you to Emilia and Yongji and Jose from our team at WHO who have worked together to prepare. Why? Because we talk quite a lot about multimorbidity. We hear from our member states that they are talking more and more about multimorbidity because they see multimorbidity as a challenge, but also because they hope that if we manage to transform our health systems such that we take a multimorbidity approach rather than just a single disease approach, particularly in older persons, where we know from the evidence and data that we have available that we are talking, for example, from the SHARE study, when we look at people aged 60 plus, and slowly but surely, I am inching towards that definition too in a few years' time. So I am taking an increased and heightened interest in these statistics, but we see that, for example, just more than a quarter of the population aged over 60 would fall into the loose definition of multimorbidity, which is the coexistence of two or more chronic conditions. And then more than half the population, for example, when we come to Czech Republic. So I think also when we see these widely disparate figures coming from the same study in countries that are literally sharing very much of the similar genetics, epidemiology, it also tells us that we need to dig far deeper into how we actually define and measure what we mean when we talk about multimorbidity. Because if we don't get this right, what can't be measured, can't be managed, can't be addressed and changed. And of course, this really matters for public health and for policy. Our health systems remain very fragmented, very much designed for single disease treatment. And this is, of course, to some extent perpetuated by, for example, the way in which our doctors, nurses, but even our therapists are educated. We tend to fragment and specialize more and more. But sometimes also when it comes, for example, to clinical guidelines, to WHO itself, we tend to go very deep, very narrow, but our health systems are crying out for us to take a step back and see the broader and bigger picture. But we also know that seeing the broader and bigger picture means going even beyond the clinical elements. And this is where public health plays such an important role, because here we are talking about the commercial determinants of health, the social and economic determinants of health. And just last week, on the 6th of May, we actually issued as WHO a global report update on the social determinants of health. And it is not fashionable at the moment to talk about these things. Yet, the reality is that politics is very much being driven by these very social determinants of health, because poverty, disadvantage, and particularly when it plays out on poor health, is leading also to shifts in voting trends and patterns. And in this sense, politicians need to sit up and take notice. But what are we trying to do? What are we trying to bring to this debate from a global public health perspective? What we are trying to bring to this debate is that, first and foremost, we want to make sure that we work with all partners to address healthy aging. We want to be far better at having people not only living longer, but living healthier. We want to close the gap between longevity and healthy life years. And this means that we need to tackle and address multimorbidity. And I think today we are also doing a great service, and we look forward to listening as WHO to your views and hearing from you, because this will be very important to feed into the work that we are doing for the first ever health strategy on older persons in the European region. We're of course addressing multimorbidity, both from a preventive approach, but also from a curative approach. And this is why we also have Jose from our primary healthcare team, because this is, we see, key to unlocking the ability to address multimorbidity in a different way. So I think we have a very tall and ambitious agenda, but like everything else, we start chipping away at it one block at a time. And today we look forward to having a keynote that will tell us what we know, what the evidence is, but perhaps more importantly, what the remaining questions are and what our strategic research agenda should be. And then we will have examples from countries, from Portugal and the United Kingdom, that will share with us how this is being brought to life. And here I will quote the Chief Medical Officer, Chris Whitty, who at the last regional committee was a very strong advocate for multimorbidity and the approach to tackling multimorbidity and people as a whole, rather than in small parts. So thank you to EUPHA for partnering with us. Thank you to the section also that is leading on this work. And Charlotte, I hope that you are now able to speak, and I guess it's over to you.
Thank you very much, Natasha. Sorry for before, technical hiccup. I'm really, really happy to open this European Public Health Week daily kickoff from a very special place, because we talk about innovation too. We talk about nothing for us without us. But today in Brussels, in European Public Health Week, we are hosting a hackathon to bring to life and walk the talk about that. So we are building, and I'll take you through it very quickly, we are building braille machine for people with blindness. And the braille machine that we are building will go to communities in Brussels and in Belgium for people to be able to emboss their own braille machine. So let me take you there, and you'll see all these people are building machines so that they can not only talk about public health, but do it. And we have here people from communities. We have here people who have been doing North and South collaboration. We have Tits, the president of EUPHA, and we have Mo from WHO, and we have all the team, so that, you know, at the end, they will get machines. And we have know that innovation is really important to do with people. It's true also for, it's true also for aging. And I really hope in the future, in the innovation partnership we have with WHO, we will be able to engage communities in all our countries with national public health association and with WHO offices that can give us their word and speak with us and work with us from the evidence and with the evidence. And with that, I wish you a very good session, and I'm looking forward to hearing the keynotes. Thank you.
Thank you so much, Natasha and Charlotte, for these encouraging words, but also bringing a little bit of urgency into the topic as well. Charlotte, I'm a bit envious of where you are. It looks a very exciting event, and wanting to get my hands on something as well. So that sounds really good. So now we start the more evidence part of our session. And first, I would like to invite Ivan Boutmans from Vrije University in Brussels, who is the head of the Gerontology and Frailty in Aging Research Department. He's a renowned expert in biogerontological research and has received numerous accolades as well. He works very closely with us in this development as well of the strategy on healthy aging. And well, we introduced to us a little bit more on the topic of multimorbidity, understanding it, the patterns, the risks and pathways. Ivan, over to you.
Yes, thank you for the kind introduction. Normally you should see my slides here now. So dear chair, dear participants, it's a great honor for me to be part of this important meeting and to set the scene on understanding multimorbidity. I have no relevant conflicts of interest to declare related to this lecture. As part of the background data analysis for the WHO Europe strategy on aging in good health, we analyzed data from the Institute for Health Metrics and Evaluation covering the entire WHO Europe region. We looked at the top-ranked diseases causing the highest number of disability-adjusted life years, abbreviated here as daily, and representing the number of years lost due to premature mortality, plus the number of years lived with disability. Here we show the percentage changes in dailies between 1990 and 2024 for people at midlife in green, and those aged 70 plus in yellow. And although for some conditions the number of dailies decreased the past 3 decades in both age groups, the percentage increase in number of dailies in the younger group for low back pain, diabetes, falls and age-related hearing loss implies a catastrophic disability burden in 2050 when they will be in their 70 plus group. And as you can see, dailies related to Alzheimer's disease increase spectacularly in the older age group. However, analyzing disability burden based on individual diseases does not take into account the synergistic effect of coexistence of 2 or more diseases, which is defined as multimorbidity. In fact, multimorbidity heightens the risk of disability and mortality over and above the risk from individual diseases. For example, the concurrent presence of heart disease and osteoarthritis of the knee increases the relative risk for developing mobility disability to 13.6 from a relative risk of 4.4 for osteoarthritis alone or 2.3 for heart disease alone. And this figure, kindly provided to me by Dr. Hamutavali Tyagarajan, shows a prevalence of multimorbidity in adults aged 50 and above in 27 countries. And besides a substantial increase with aging, there is also a large heterogeneity between countries. Pooled meta-analysis reveals that average prevalence of multimorbidity ranges between 40 and 50% in older persons aged 60 years. Now, this implies that people are living longer but not healthier, and over the last century we have added decades to life expectancy, but we have not added decades to health. We are living longer, but we are also spending more years in poor health. And as shown in this graph, the difference in life expectancy and healthy life expectancy is on average 5 years, and this gap tends to increase. Schematically, we expanded lifespan, living a longer life, but not a healthier life, thus implying more years living with diseases and disabilities. And if we want to expand health span, we need to compress morbidity by living a longer and healthier life and thus increasing the number of healthy years. However, as you know, health does not mean just the absence of disease. Healthy aging is defined by the WHO as the process of developing and maintaining the functional ability that enables well-being in older age. And in this concept, functional ability is defined as all the health-related attributes that enable people to be and to do what they have reason to value. Functional ability depends on the interaction between an individual's intrinsic capacity and on the environment, which can be more or less challenging. Intrinsic capacity is defined as the composite of all the physical and mental capacities that an individual can draw on at any point in time. And when intrinsic capacity fails to meet the environmental challenges, functional ability decreases, thus leading to disability. Now, intrinsic capacity is a holistic concept encompassing different domains as shown in this figure. On the top, you see the domains of expressed capacities, including locomotor capacity, such as capacity to walk or stand up from a chair, cognitive capacity, including memory and capacity to process information, sensory capacity, such as vision and hearing, and psychological capacity, referring to mood state and resilience. The lower part shows vitality capacity, considered as the underlying physiological determinant of intrinsic capacity, and it encompasses 3 subdomains. Energy and metabolism, reflected by fatigue sensations and body composition, neuromuscular functions such as hand grip strength, and inflammation and stress response of the body. Now, I provide you now some examples from the literature. On the left side of this slide, you can see the level of intrinsic capacity according to the presence of different chronic diseases. The orange box plot represents those subjects without any chronic disease. And as you can see, intrinsic capacity is lower with increasing age. And more interestingly, for most chronic diseases, the range of intrinsic capacity partially overlaps with that of those without chronic disease. And this indicates that although impacted by disease, intrinsic capacity can be either high or low, regardless of the presence of disease. In the right figure, you can see that contrary to intrinsic capacity, multimorbidity is not directly associated to incident disability after 2 years follow-up in this study. Multimorbidity showed only an indirect association with incident disability by means of intrinsic capacity. Another example comes from the Brussels study on the early predictors of frailty that I coordinate. Butterfly is a unique cohort of 405 community-dwelling subjects aged 80+. Although these subjects were non-frail at baseline, they showed on average 3 coexisting diseases, thus pointing to a relatively high prevalence of multimorbidity. Here, we calculated the most common multimorbidity indices that take, besides the absolute number of diseases, also the severity or the risk for disability and mortality into account. And surprisingly, none of these multimorbidity indices was significantly associated to the prevalence of reduced gait speed in this population. Furthermore, prospectively, we showed that the combination of low muscle endurance and increased fatigue, 2 biomarkers of the energy and metabolism subdomain of vitality, was significantly associated to the occurrence of disability at 1 year follow-up. And again, comorbidity was only associated to loss of gait speed and activities of daily living indirectly. Recently, The Lancet published an update of the 14 modifiable risk factors for dementia. When all risk factors are eliminated, the risk for dementia can be reduced by 45%. When looking attentively to these risk factors, most, if not all, are related to intrinsic capacity and the environment, thus perfectly fitting with the WHO framework of healthy aging, which defines functional ability as the interaction between both intrinsic capacity and the environment. If we want to reduce the burden of disease with advancing age, we need to focus on these healthy aging components instead of on the diseases themselves. The proposed preventive actions are well known. It is about optimizing intrinsic capacity by means of healthy nutrition and physical activity, addressing hearing loss and vision loss, and environmental aspects such as education, social contacts, and air pollution. Although emphasized here in the context of dementia prevention, these interventions are rather generic, as they will also prevent many other chronic diseases. To end my presentation, I will use this figure of the WHO showing the theoretical trajectories of functional ability and intrinsic capacity. When functional ability continues to decrease, disability occurs. As an example, today in Belgium, the heart of Europe, Belgian men and women aged 65 years will spend respectively 32% and 43% of their remaining lives with disabilities. The current healthcare system is rather reactive, meaning that older persons usually benefit from health counseling when clear disability is already present, and consequently, care for older persons comes often too late to prevent disability. Low intrinsic capacity is typically the stage preceding the occurrence of disability. About 50% of all community-dwelling older adults show reduced intrinsic capacity, which is associated with up to 3-fold higher risk for negative health outcomes in the very near future. When loss of intrinsic capacity is identified timely, this negative trajectory is still reversible and disability can be delayed or avoided. The moment when the trajectory of intrinsic capacity starts to dissociate from that of functional ability represents a window of opportunity for timely prevention and intervention, because older persons have an important potential to regain intrinsic capacity by means of non-invasive and relatively inexpensive modalities. Here too, we need valid and sensitive biomarkers to identify the opening of this window of opportunity and thus targeting those older persons at risk of low intrinsic capacity and disability. As this requires regularly monitoring of intrinsic capacity, these biomarkers should be easily measurable and preferentially embedded in a user-friendly digital e-health ecosystem, thus allowing older persons to self-monitor their intrinsic capacity themselves or with the help of an informal caregiver. So conclude, if we really want to increase health span, we need to reorient our reactive disability and disease-based focus of healthcare towards a proactive intrinsic capacity-based approach. I thank you for your attention.
Ivan, thank you so much for introducing to us a little bit more of what is behind the numbers of multimorbidity, what is producing it, how to prevent it before and identify what are some of the markers that can help us identify it early. But also, I think you referred a lot to the environment as well, where people are developing, and there's some determinants as well that are very important as well, markers for or risk factors for multimorbidity, such as the social determinants and other determinants as well. So that leads well to our next presentation. But before I introduce our next presentation, I would like to just invite all the participants to pose some questions in the chat in the meantime as well. We will try to address them at the end of the presentations, but also there might be some space to speak as well if you would like to. So the next presentation is by my dear colleague Jose Cerezo, who works for the WHO European Center for Primary Care, and he will introduce to us the concept of population health management. And I'm really excited about this because this gives some information as well to our colleagues who are listening of what the public health community as well can do to identify some patients with risk factors and other determinants that might be important to address early to prevent multimorbidity, but also then once it's set to manage it. So Jose, over to you to introduce us to population health management.
Thank you very much, Emilia, and good morning to everyone. It is a pleasure for me to be here today with you, and I'm going to share the work that we are doing in the WHO European Center on population health management, which relates very well with our today's topic of discussion, which is multimorbidity. So health systems globally are facing a myriad of challenges which are often interrelated, right? Widening health inequalities, different health workforce related issues, budget constraints, very important also a shift in people's values and expectations towards the health system. And of course, and it has been discussed among one of them, a very important one is aging and multimorbidity. But fortunately, also next to these challenges, there lie new opportunities. And one of them is the increasing system-wide digitalization of health systems, particularly after the COVID-19 pandemic. Big data, we have an availability of data as ever before, and of course, the inclusion of artificial intelligence. Taking them together, they can allow the better integration and interoperability of data, for instance, between sectors, health and the social care sector, and increased availability and analysis of big volumes of data, including the formation of big cross-sectoral databases that can have multiple resources, and related to that one, the enhanced precision of predictive analytics, which they have several applications, for instance, the prediction of public health trends, use patterns, or care gaps. And here is where population health management comes. Population health management can help address some of the challenges that I have presented in my first slide, building on health system features, but also on the new opportunities that I have just described. We define in WHO population health management as a people-centric, data-driven, proactive, and collaborative approach to improving both the health and well-being of a defined population, taking into account the difference within that population, as well as their social determinants of health. Now, the most important elements of population health management, they can be summarized into a cycle of 5 steps. The first one is defining a target population, which can be one municipality or the catchment area of a primary care provider, for instance. Second, health assessment and segmenting the population in different subgroups with share similar needs based on a cross-sectional analysis on needs. Third one, stratifying the population based on the probability of occur of events in the future. Fourth one, tailored service delivery. So making sure that service delivery is tailored to the needs of different population subgroups and individuals. And fifth, evaluation and improvement. But what's the aim of all of this? Well, at the end, population health management provides a more sophisticated and systematic understanding of the populations and their social determinants of health, drawing on both quantitative and qualitative data insights. And this enhances something that it is absolutely critical for multimorbidity, which is the provision of proactive, targeted, and tailored care in the right time, at the right place, by the right provider in a coordinated way. As Natasha mentioned in her opening remarks, of course, addressing multimorbidity requires all providers from within and beyond the health sector working together in a coordinated way. So this is another visual representation of what population health management is about. There are different entry points, different processes that can be used, but in many countries and places, the starting point is the analysis of electronic primary care records and public health databases. By using and analyzing this information of visits to primary care, visits to secondary care, admissions, pharmaceutical prescription, and other factors, including information related with the social determinants of health, the population can be classified into different subgroups and risk and allow for the identification of those that have highest complex social and clinical needs. Of course, this information is very critical for joint action of individual care providers, including primary care and public health providers. And we think that that is something critical because we see currently in many countries a gap between the two. So on the one hand, we see that public health services has been historically more focused on improving population health outcomes and addressing health inequalities at a national or a regional level, but they have paid less attention to the service delivery causes of poor health outcomes. And on the other hand, we see that individual health services tend to be very, very focused with managing the increasing and ever-growing demand and addressing access barriers to health services, but sometimes they overlook the importance of the social determinants of health. And we think that population health management can help close this gap. It can do so by bringing a population perspective into clinical practice, for instance, by providing individual care providers and primary care centers, for instance, information at the population level on the social determinants of health. But it can also do so because the classification of a population into different subgroups that are homogeneous and share the same risk and needs can be very useful for the deployment of a proportionate universalism approach to the way in which healthcare is provided. So This collaboration can lead to things at community level that are very important, such as the identification of subgroups and individuals at higher or at risk of high or under service utilization, the identification of subgroups and individuals with higher clinical needs and social complexity, and also the identification of health inequalities at a community level. But let's take it now more specifically to today's topic of discussion, which is multimorbidity, where working at this interface between primary care and public health is particularly important. As you can see in the chart, multimorbidity appears between 10 and 15 years earlier in areas of higher socioeconomic deprivation. This is absolutely critical because, of course, if we were to prevent multimorbidity, we know that individual prevention is not enough. We need public health measures that address the root causes of diseases. But even if our aim is not to prevent, but to manage multimorbidity proactive, which is what my presentation is about, this collaboration between primary care and public health is critical. First, to be able to identify who is these people within our communities and being proactive to them, not waiting for them to come to the clinics or for an underside event to happen, but to work for them proactively. And second, this collaboration is also critical to ensure that the responses to multimorbidity are not only biomedical. And this is critical. One example that I think that illustrates this very clearly is the evidence that we have on the bidirectional association between multimorbidity and social isolation. What that it tells us that addressing multimorbidity is not only about making sure that people is in the right treatment regime or that they receive individual counseling and interventions for addressing risk factors. Addressing effectively multimorbidity is also about promoting social participation and addressing loneliness. And this is something in which public health agencies can play a very, very important role. Now I'm going to finish with two examples on the use of population health management for patients with multimorbidity. The first one is patients with multimorbidity can be identified through population segmentation and risk stratification processes. This is an example from Spain, but there are similar examples in other countries. As you can see, at the population level in the left, you can see a population pyramid of a primary care catchment area, and you can see how chronic complex patients with multimorbidity are distributed based on age. And on the right side of the screen, you can see individual information in the primary care electronic health record, which includes the complexity score of the patients with a patient with multimorbidity, including the risk strata in which this patient is. Of course, this information can have multiple uses, but one of them is case finding patients with multimorbidity and making sure that they are included, for instance, in patients with in programs for complex chronic patients. And related to that, this can also inform the development of integrated care pathways for these patients, which are based on multimorbidity and not only on single diseases. And it can also inform the development of shared care plans who are individualized and that are shared between different levels of care and sector. And then the second example is about addressing multimorbidity, not from a biomedical approach, but from a different but absolutely critical approach. Patients with multimorbidity can be identified through the population health management process that we have seen. And once they are identified, they can be connected with a range of non-clinical resources that are available at the community level to address their needs. How does work in some countries? These patients can be proactively identified by primary care, and they are formally referred to these community resources that may include cultural centers, sports centers, welfare support services, patient support groups, so that their needs can be addressed then. In many cases, those community resources have been previously either identified or validated by public health services. And some examples of good practice that we see in some countries is that public health agencies are involved in the development of electronic suppositories of maps of the resources available so that they can really facilitate the connection of patients and people with these resources available in the community. That's all from my side. This is my last slide. We have been working about it in the center, and we have published a policy paper and a journal article that you can access through the QR code. And over from my side, Emilia, back to you. Thank you very much.
Thank you, Jose, very much. And there is a question already in the chat for you that it's asking you, what is some of the minimum data that you could use for risk stratification? Could you respond to that before?
Do you want me to respond it now?
Yep, that would be really good. Yeah, so we can move
Yeah,
then.
So I guess that it depends. It depends a lot, and sometimes that we tend to say when we work with countries is that you need to work with what we have, and based on that, you need to keep building on that, because there will never be the perfect set of data for population health management, nor in terms of quality or in terms of amount. You know, this is actually an ever-evolving process that once you get into it, you see the needs, you improve it, you try different things. So there is not a minimum set of data that we can prescribe countries or that we can tell. As I have mentioned before, countries normally they tend to start by the information that they collect routinely in the primary care electronic health records. Why? Because there are a lot of interactions between the population and the primary care providers. And there normally is very rich information that can be very useful to analyze needs or to predict needs. Information of diagnostics codes that they have, information of the number of prescriptions that the patient have. In the best cases, also information on the social determinants of health at the individual level, and so on and so forth. So I would say there is not a minimum set of data that I can speak about, but countries normally start by what they have, normally starting by primary care databases.
Excellent. Thank you so much. And I think whoever has worked in primary care or in any clinic, or there's always a lot of data. We collect a lot of demographics as well. And as we know, it's age and socioeconomic determinants that are the main drivers for multimorbidity. So I think we all have a place to start in our clinics, and we will hear more about some examples as well right now. So I think first I'll introduce David Sgorbati. And I'm really excited to hear David's presentation. When we met a couple of days ago, he had a very interesting background. David is an experienced computer scientist who has worked for several national, regional, and provider teams in the NHS in England, and is contributing to the deployment of machine learning techniques to improve patient care. In his presentation, he will give us an insight on using advanced analytic techniques to support problem solving across organizational boundaries. I think that sounds very interesting for a lot of us from the public health community. So David, over to you.
Good morning. Very nice to meet you all. And it's an absolute pleasure to be here. I'll be sharing my screen. I have a few slides. Let me just share my, my internet connection is pretty poor today, which is causing a few issues. So I'll probably switch my camera off while I present to save a bit of bandwidth. And hopefully this will work now.
We can hear you well, David, yes, but not yet seeing your presentation. We can't see your presentation.
Good start. Of course, my presentation is okay. Hopefully you can see my screen now, and I will start from here.
It's starting. Yes, perfect.
Wonderful. Here we are. Right, great to be here, and thank you so much for the introduction, Emilia. Yeah, I'm a computer scientist by background. I spent about 10 years in the private sector doing private sector things, and then I thought, oh, maybe instead of making money for rich people, I should work in the public sector and try and be one of the good guys. I've now been working in the health economics unit for about 3 years. So we are data scientists, data engineers, health economists. We work in the National Health Service in England. but really we will collaborate with any government. At the moment, a lot of our work is in Ireland. We work with academia, with the commercial sector, and so on. It's really good fun. I do love what I do. Thank you so much for the. We've spent a lot of time researching ourselves, partially in collaboration with the Real Centre here in England, appreciating that the number of older people is going to increase, but also we really want to understand the relationship between getting older and being healthy. Someone had posted in chat a question about dynamic equilibrium. So there's this idea that lifespan has increased. Before, let's say around 60, long-term conditions started appearing and kept on accumulating over the next 10 years or so. And then around 70, usually death arrived. As the lifespan increased, there's a question about, will that slope just be slower? Will the appearance of long-term conditions start later? What's going to happen? And one popular theory is the one of the dynamic equilibrium, which sees an equilibrium between starting early and accumulating more quickly. So we worked with Northwest London, so big patch, over 1 million people, quite diverse, to try and understand how aging is happening there. What is the pattern, and how do we need to intervene? To do that, we collected healthcare data, social care data, demographic data, wider determinants data to the best of our ability. Of course, it was far from perfect. Absolutely, we did not have everything we wanted, but still enough for us to show that it's actually a bit weird. There's a gradual then sudden pattern in that population. So the onset of long-term conditions does start around the mid-60s or so, grows slowly, and then there is a big increase in speed towards the end of life. But the very important message that came strongly from the data was that this pattern is very, very, very different in different communities. So in more deprived communities, this was drastically different, and that whole curve was shifted to the left much, much, much sooner. So it's very important to make sure that we're always, as was being highlighted earlier, thinking through that to the different segments in our population. So what are we doing with this? We're a very hands-on team. We go out and help solve problems across the country as much as we can. Multimorbidity is tricky because budget lines across different conditions tend to be divided. People tend to be aligned in teams across diabetes, COPD, CVD. So a lot of the demands on us have been quite specific. So we need to work within a specific condition and then try and broaden out our approach to make sure that what we do is comprehensive, cutting across population and all the services. A lot of our focus at the moment has been starting from COPD. Very large problem in many areas, requires proactive multidisciplinary treatment, and we're currently working to try and determine the probability of progression from COPD to multimorbidity based on social care data, patient activation measures that are more important every day with the availability of digital tools, really understanding how the level of ability in different segments of the population to take health into their own hands and use, let's say, an app on their phone to understand their condition, but also really looking at housing arrangements and social isolation information where possible. Of course, that's very important. We know that household level data is absolutely crucial, understanding COPD and multimorbidity. We know about the importance of social isolation. There are gaps, but we are still striving to build models that can support that in as much detail as possible. Now, we work quite a lot with Coventry. It's an area in the Midlands with fairly significant COPD population. What we've been doing with them was trying to understand the current picture of the population, of the services, and make sure that better decisions could be made across services, breaking down the barriers that divide healthcare and social care, trying to bring in people from the council to look at the housing, trying to bring in the GPs to talk with their colleagues about what is truly happening across the pathway. So we started by really understanding the population, looking at the distribution of COPD. Here's just a slice, but underneath this, we've also looked at the deprivation, the ethnicity, and all those factors that make people fall into different segments. We've looked at the different interventions that were being put in place across the pathway by different colleagues in public health, primary care, secondary care, and so on. And we built these big data packs. Now, please take this with a pinch of salt, but I'm a computer scientist. I could spend my whole day looking at data and I'll be happy. I just love doing maths. I'll sit down and scribble maths on a piece of paper all day long, but that's not gonna change anything. Yeah, what's gonna change things is to bring people together using the data as an anchor to have better conversations about what is happening across the pathway. So what we've done is we've mapped all these interventions across the spend and the benefit to the population in different segments. The moment we had all this mapping, we could have much better conversations about whether the spend was well allocated, whether things were appropriate for the populations, and where we should or should not invest more. Now, some of the things on this chart might be surprising. There is a tiny triangle there showing warm home schemes, and you could look at that and think, well, that's just boiler and prescription type stuff, just making sure that people can switch on the heating. But it's such a small triangle. Is it making an impact? Now, by having these conversations, bringing patients in the room, bringing all the people from across the pathway, the clinicians and the managers, we can look at that and go, right, that's a small triangle, but that is what makes the most difference for the most deprived people in our population. That intervention has a massive impact on us. And going from this, we've also looked at other interventions. So this is modeling, looking at education programs, and it shows how by introducing a new intervention, we can hopefully shift the costs and have a better impact on our population. So big thing for me is bringing people together. And I'd like to think that we're a fairly charming bunch. As you can see here, we're in a band together. We make music together. How much better can it get? So we do hopefully can bring people to have a productive conversation, but really being able to bring in the data from the wider determinants to anchor the conversation, to give people something to disagree on is hugely important. And you might raise your hand right now and say, well, David, I don't have data for this and I want to talk about that intervention, but there's no evidence. That's okay. That's absolutely fine. As Jose was discussing earlier, start from the best possible point of reference, and then use your common sense, use experience from all the stakeholders engaged, and build together on those foundations to move change forward across sectors. Multimorbidity is a big, complex problem. We can no longer afford to be divided by traditional medicalized team structures or old school separate budgets. All of this needs to bring us together. So at the moment, we're very focused on the three shifts that have been very much discussed over here: the analog to digital, hospital to community, and sickness to prevention. Data will always be the big foundation of what we do, but ultimately making sure that those structures and conversations are supported by the data to give us the best possible outcomes for the population is what we're truly striving for. Thank you.
Thank you so much, David,
much.
for your presentation and for showing us as well that the power of data to have conversations. I noticed that in the chat, we also got a question about comorbidity versus multimorbidity from Piroshka, because I think we saw in your presentation, you referred to comorbidity in the figure. Well, I see that already Ivan has kindly responded, but maybe we can also clarify here, how do you use those terms differently, David? Why do you refer to comorbidity in your presentation versus to multimorbidity?
So usually I'll look at comorbidity as the coexistence of additional conditions in relation to a primary condition. Multimorbidity often looks at the more holistic package of, without kind of assigning a priority often. So often in our conversation, we tend to talk about comorbidity because of these old school traditional structures.
The budget lines you were referring to.
Exactly.
Okay, very useful. And I think it's important also to speak about the language that some of the doctors or some of the providers might be having, or some of those budget owners as well, which is also one of the key competencies that we've been discussing for many years as well of the public health workforce in general. So very useful. Thank you so much, David. And I think it also, now we go to Inês Vale from Portugal. She is a family doctor in the Litoral Alentejanos local unit. And this is located in the southwest of Portugal, which is, I unfortunately haven't been in that area, but I hear it's a very beautiful area. But at the same time, fewer hospitals and health centers, long travel distances to people as well to be able to get to centers, and an older and a rapidly aging population too. Inés has been a part of a team from the local health unit doing the care pathway since 2022. And she will show us how they are improving the life of patients with multimorbidity in this local health unit of Alentejano. Inés, over to you.
Thank you. And you're welcome to visit us anytime. Good morning, everyone. First of all, I'm really glad to be here and share our experience in our local unit that started in maybe 2020. And I'm gonna show you briefly what happened between that time and until now. This is my agenda. So here we are working for the inhabitants of a large area, as you can see, that red area on the map. And yes, indeed, we have terrible roads, we have few public transport available for the population, and we also have an aging population. So you can expect that people will have overlapping long-time medical conditions. And we also deal with the shortage of health resources. For instance, at the beginning of this project, we only had one cardiologist and one pneumologist, and they were not working full-time. And now we still have 23% of the patients that still hasn't family doctors. So in this scenario, we felt that we needed to do something to change the way how we provide care to our population, to make it more appropriate and to use the available resources. Well, in this context of increasing aging and chronic diseases and working on the field as healthcare professionals, we felt that people suffering of multimorbidity many times ended in an acute scenario of their diseases in the ER. And they had a fragmented healthcare answer. And also, patients had a feeling of being lost after the hospital discharge. So there wasn't like a big plan for the future for them. And in 2020, our local unit integrated the Joint Care Action Jade Care. So we adopted the Basque best practice of clinical pathways, and we adapted it to our conditions that we have at the moment. We think that clinical pathways could be one way to provide integrated care, as they are person-centered, they are based on consensus between different types of care, and also they're a strategy that reinforces the coordination between different teams and types of care and the continuity of care throughout the time. So in terms of the process of implementation, we started in 2022 with meetings between doctors and nurses from hospital and primary care. We also invited patients, caregivers, psychologists, social workers, and community pharmacists so that we could build these care pathways in a co-creation design. For the writing of the consensus and decide how we would build the care pathway, we create a core working group, which I'm part of, and we decided to start with patients with at least 2 of these 3 conditions: heart failure, COPD, and type 2 diabetes. For us, what made a huge difference was to organize local teams. So one team stays at the hospital, and one team for each of the 5 primary care centers. So these teams, they coordinate with each other whenever the patient changes the state. For instance, if a patient is getting worse or is discharged from hospital, so that we all are speaking in the same language and the patient understands what to do next and what to do in any circumstances. So each team is composed by nurses and doctors, and they ensure communication, and they make patient access easier. Also, they solve most of the patient's needs, and many times remotely, which is really helpful. Each team was provided an email and a cell phone, but this cell phone is shared with the patients so that we increase accessibility to healthcare professionals. Then we checked the eligible patients that we had. In the first time we had 1,500, and now we have a little bit less patients in the clinical pathways. And I'm going to show you, this is probably very similar to other European countries or countries from across the world. You see that our patients in the multimorbidity clinical pathway range between 70 and 90 years old. That's probably the same as other countries. And then other thing that we built which was really life-changing was that we built a digital tool with the collaboration of a Portuguese startup company for all the professionals involved in the clinical pathways. And the digital journey consists of a real-time digital mapping, has decision support algorithms, and also automated symptoms questionnaires. The digital mapping is real-time and has interoperability characteristics so that it communicates with the other systems that we work. I don't know if it's the same in other countries, but we have so many applications, so it's really important to have interoperability. And about the questionnaires, they are sent through text message, but if you see the age of these patients, maybe it wouldn't be easier to get the answers done by a smartphone. So if a patient doesn't answer the questionnaire, they receive a call and then they can reply to the questionnaire by voice. So it made a really difference. When the patient reports symptoms through the questionnaire, the local team receives an alert and then they can call the patient or the caregiver. And first, the local team repeat and validate the answers given. And most of the times what happens is that the local team suggests some changes or habits in medication, and then you solve the problem that the patient has. But in a few cases, it is necessary for the patient to be evaluated in person. So we went live in October 2023, and starting at this point, the clinical pathways were introduced to patients one by one, so that we ensure that every patient and caregiver understands what is to be part of a clinical pathway, and what tools do they have available. And now we have monthly meetings that occur between the local teams and the core working group. Also, we keep in touch with the company that helps to make the digital journey, because we always keep improving the clinical pathways and the digital journey. So for us, what's next? We are now launching a program within this project that makes it easier to diagnose COPD and to coordinate with a rehabilitation team that now is working, both of them are working in the primary care, which is really good. And we're glad that people have it locally and don't have to go to the hospital whenever they need to do the spirometry or whenever they need therapy. So we think this is amazing. Also, we are building bridges with nursery homes because, you know, that's where many elder people are and they deserve the same care as the other people. Also, we have one member of the core group working on patient enablement assessment. And in the end of this year, probably we will have a value-based study that will be performed by an external entity. I'm going to show you just a few outcomes that we have now. So more than 9,000 questionnaires were now sent to the patient. And we are very proud to have this response rate of 55%, because despite the age of these patients. So this is really good for us. 44% of those answers, they produced alerts for the local teams, but only 2% of these alerts resulted in clinical assessments in person. So that's fantastic. Also, as a result for the first year, we have done a cohort study with 443 patients, which showed a statistically significant decrease in ER episodes of 46%, and also a tendency in decreasing hospitalization of 48%. We asked the company that created the digital journey if we could also automatically send a questionnaire based on patient-reported experience measures, so that we can have a real feedback of our patients and how do they feel being a part of these clinical pathways. However, the patients can only answer them through a smartphone or computer. They cannot answer by voice. So we have only 19% of answers. But even so, it was a surprise for us that most people answered always to this question. They feel that the professionals are available to listen to you and take your needs and preferences into account when developing your care and treatment plan. And many answering always or almost always, when we ask what do they feel, if there is good communication and coordination between the primary care center and the hospital in order to improve your well-being and quality of life. So in the first anniversary, we invited some patients and caregivers to join our monthly meeting, and we listened to their experiences. it was really important for us to hear, for instance, from this patient. She's 91 years old, and she refers the importance of this program in bringing more confidence to face her problems. And that's it. Thank you, everyone.
Ines, thank you very, very much for your presentation and showing us as well. I mean, the conversation about how to handle multimorbidity in older people has been going on for many, many years, I think. But seeing it implemented in one community with where you're talking about 1,000 and hundreds of patients, and then coming down to like how many patients feel that you are addressing the care needs according to their preferences. I think it's very powerful as well. And then going back to this one last patient that you showed us as well, and how that all the being able to adapt the care to her needs, bring the people, the team closer to her, has make her feel more empowered to address her conditions. I think that's also shows how these changes in primary care and in the way that we organize the services helps patients and helps also reduce costs and increase efficiency as well in the way that we deliver care, and that's very important. There's a question in the chat actually from a colleague from Boglarka who's asking you how to implement integrated care for older people in a country. And I know you're speaking on behalf of your local health unit. The person is asking, is it through hospitals first? Is it physicians first? Is it university? Is it policymakers? Is it someone else? And I imagine that depends, but what's your opinion on that, Ines?
Well, in the last webinar I was presenting, one member of our core group said something really important. That is, it doesn't matter how you start, but start it in any way, because it really depends on how your organization works. What do you have available, for instance? So we have something that really helped us, is that we were not starting from scratch, because we already have a case management project since 2017. So we already had good communication between primary care and hospital. Okay, and maybe you should start communicating with people that are interested in changing care and want to make a difference. And you should start from there, and then you see.
Yeah, and I think discussing with you and other colleagues as well in Portugal, we understand the motivations can come from different places. It might be that the motivation is to save costs, but for example, if you work with civil society, perhaps the motivation of patients is to improve the care for them. So wherever you find the champions, I guess that's the place to start. Thank you so much, Ines, also for being a champion as well for improving multimorbidity care for older patients. And Sultan, I think with that, I can hand over to you, because I think we answered a lot of questions from the chat already. So now we go to the last part of our session, which will be moderated by Sultan Umbari from the EUPHA section on healthy aging. And Sultan, over to you.
Thank you. Good morning, everyone. I'm Zoltán Ungvári, president of the EUPHA Health Aging section, and it's a pleasure to welcome you at this today's session. So this event reflects a strong and ongoing collaboration between EUPHA and the WHO Regional Office for Europe, working together to advance health aging across the region. To get started, let me highlight a few questions that we are particularly interested in today. First, I would like to address our panelists. What programs exist in your country or community to support digital skills for older adults and patients with multimorbidity? And I would like to ask the audience to raise your hands, or rather type in the chat to comment in the chat box to participate in the discussion, and we can relate your questions to or comments to the panelists.
So then, if I may as well, in addition to that, I mean, there's two ways in which you could comment. We have also put in the chat, I forgot to mention this, there's this, the AI-based PERA tool that we have in WHO. So if you also would like to share your examples through this tool as well. We will collect them, and this will help us also in the development of the strategy on healthy aging that I mentioned in the beginning. So in the chat, there's a link to that tool. There's the question there. But I also, would be so happy to hear colleagues share their examples here as well.
Aha. So I don't know. Oh, so Yongji, I think, joined us, if I see correctly. Yongji, are you here? He just commented.
Yes, I'm here, and I posted the questions that you've asked on the chat. So looking forward to hear from our colleagues and participants your thoughts about how we can address multimorbidity.
I don't know how the so the participants cannot can they be given the microphone?
Yes, they can raise their hands if they want to come in and respond to your question. And they can also put in the chat, and they can also respond in the PERA tool. There's 3 ways in which you could make your voice.
I see Piroshka Ostlin raising the hand.
Yes, she's ready to speak. The microphone is open.
Can you hear me, please?
Yes.
Can you hear me?
Yes, Piroshka.
Okay, super. Well, thank you very much. As to the, maybe I can comment a little bit on the first question, because I think indeed that it is important to develop the programs for the elderly to enhance their digital skills. But what do we do if it is not the lack of digital skills that and availability to the digital tools that is the problem or the barrier for using these digital services? And I have a good example from Sweden, for example, where the elderly have high digital skills using internet comparatively more than in most other countries. However, a Swedish study showed that few elderly above 65 actually use the services. So there was a deep interview study, exploring the reasons for this. And there was concerns among the elderly about the funding of digital consultation services. And there was a mistrust for private providers who are often the ones offering these services. The second main reason for not using the services was the lack of knowledge of available services and what types of consultations were possible. And the third was a lack of perceived usefulness of digital services, as they felt satisfied with their current form of primary healthcare, which is a kind of a good thing for Sweden, that patients are happy with the primary and traditional services. But these were the 3 reasons. So I think we need to think about putting more effort in building trust for digital services for elderly, also provide much more information about the services, what is available, and also kind of the benefits for them, for the services. Thank you.
Thank you, Piroshka. And do the panelists want to comment on what we just heard from Piroshka? Yeah.
I'm happy to come in from a perspective here in the UK, that the findings of local research, I believe, were published by the Health Foundation earlier this year or last year. Very similar pattern in terms of trust and perceived usefulness being an additional barrier. That was both with the older patients, but sometimes even with staff. So it is sometimes tricky to communicate that. There's been a bit of a shift here. For a few years, we went, oh, digital is here. That's great. Let's try and make everything digital, and let's go digital first across the board. Luckily, over the last few years, we've been pulling back a little and try to make sure that it's digital first, but digital first does not mean digital only. And ultimately, we need to bring people along. We need to be able, as you were saying, Piroska, to communicate that usefulness, take people one step at a time with us, and support that transition. We need to be a bit careful. There's a lot of power, but also a lot of culture to shift.
Excellent, David. Ivan, do you have any comments or thoughts?
Yes, sure. You're addressing to me, yeah?
Yes.
Yeah, sure. Yes, I can. I can comment. I think indeed that I mentioned in my presentation that I want to promote digital tools in order to assist people in creating awareness about their own longevity trajectory. I think that is really key in order to empower aging persons in order to adopt healthier lifestyles to prevent multimorbidity and disability. But this doesn't come automatically, of course. And I think that a good concept that connects also with the last presentation is the idea of the concept of healthy aging centers, where people can get advice on how to estimate and monitor their capacities, and also instruct them on how to adopt and embrace these digital solutions, and make them more self-supporting in a certain sense. And depending on the digital literacy and user friendliness of the systems, some of them might be able to continue their process more independently with the digital tools, and others might need more face-to-face physical interaction with staff of such healthy aging centers. But we must realize that it will not be possible because there is insufficient manpower, manforce, to accompany all aging persons individually in their process. So I think that digital tools are necessary to implement. Thank you.
Thank you. That's excellent. Jose, you also raised your hand. Please comment.
Thank you, Zoltan. No, just very briefly, building on what has been said, I think that as we discuss more and more about digital first approaches, which of course are not digital only approaches, I think it becomes more and more critical for health system and healthcare providers to have more and better nuanced information about what is the digital and health literacy of the population. I think that's an area that that's totally missing and is worth investing. And not only the digital literacy, but also what is the willingness of patients and populations for using digital solutions, to address their diseases. I think that's an area that is worth investing because sometimes, and particularly during the pandemic, sometimes there was a rollout of digital tools without a careful evaluation or without carefully thinking to what population subgroups this could benefit the most. And I think that is going to be an area of discussion in the future. So more information about digital literacy, willingness to use digital tools, and also more informed information about for what services or type of diseases digital tools can really address a gap, and for which other issues the traditional in-person face-to-face contacts is still the best option.
Excellent. I think Jose has raised excellent points. Professor Rosa Adain, Vice President of the Health Physics section, indicated in the chat that she would like to comment, but could not manage to raise the hand. Can we give the microphone to Professor Adain?
Thank you very much, Zoltan. I don't know what is the problem, but on my system, I cannot see the option to indicate that I would like to comment. I mean, to raise my hand. That's the reason why I was sending a short message to you. But there is a little gap between the discussion and my comment, because I would like to add something to the comments of Piroshka and Emilia. I fully agree with them that in addition to the in-person meetings and monitoring health of aging and elderly populations are very important. And also the digital assistance can be very, very helpful. But what I would like to mention that to use the digital support, digital health literacy, and in general, digital skills are needed, and they are enormously important. And I don't know what is the situation throughout in the WHO European region, but I know that certain data are available on the digital skills, on the digital health literacy of elderly population in one of the most handicapped region of Hungary. And as far as I think, I cannot see the complete list of participants. Our colleague Eva Biro is with us, and she can comment what is her their experience from the survey on the digital health literacy of elderly in the population. And in addition, I would like to underline the statement of I don't know whom, that the health team, not definitely the healthcare team, but the team which can improve health of the population. This is a very important issue. And in addition to the primary care general practitioners, primary care, other health professionals involved in the work of the primary team are very important. And regarding the Semmelweis study and the Caring University model program of the Semmelweis University in Budapest, we have certain experience regarding the teamwork. And I think that Vince Fazekas-Spongor is here because I have seen his comment before, can comment this issue on the composition of the health team in a program which targets the health improvement of health of the aging and elderly population. That is what I wanted to say. Sorry.
Thank you so much, Rosa.
Thank you very much, Rosa. And Vince Fazekas-Spongor raised his hand, so let's give the microphone to him.
And maybe if I can just ask our colleagues Vince and Eva, who have their hands raised, to be short in their intervention, because now we will need to close soon. Thank you. Vince, can you
Vince,
unmute
floor
yourself?
is yours. Vince, floor is yours.
I know. Can you hear me?
Yes,
Okay,
yes, we hear you.
okay, great. Sorry, there was a technical issue. Yeah, okay, I'd just like to briefly present on what we do here at the Semmelweis University to recognize and manage multimorbidity very quickly. So as a part of the Caring University Model program, we created a Fodor Center. The Fodor Center's goal is basically to meet the challenges of an aging population through the early identification and prevention of diseases. And at the heart of the Fodor Center, there is the preventive medicine facility that I coordinate, and we work in close collaboration with family physicians. And we have a very big team helping our work because, tackling and managing multimorbidity, it needs a holistic approach, but we also, need the very collaboration of different people working in different areas within the healthcare. So we work very closely with the occupational medicine services, dietitians, mental health professionals, sleep experts, physiotherapists, and exercise specialists. And whenever someone arrives at our clinic, they first take part in a very comprehensive risk assessment. And based on the findings, we initiate diagnostic tests with the goal to, uncover other potential comorbidities and multimorbidities. And this information is very important for us because depending on the type of comorbidities our patient has, we have to tailor our treatments, not just the medical treatment and classical therapy, but also the lifestyle intervention. And these lifestyle interventions are very good because, of course, if you improve someone's nutrition, this will have a positive effect on several comorbidities, hypertension, diabetes, and so on. And the goal for us is basically to create a model program that can be implemented within the country in which prevention and preventive medicine, recognition of diseases at the earlier stage play a very important part. And the goal is to move the healthcare system to a more preventive and anticipatory system.
Thank you
just a
so
little bit
much,
of yeah.
Vince.
Okay,
That's
thank you very much.
very interesting indeed, and I think very central to what we've been discussing in the event today. I see we still have Eva Biro with her hand up. Eva, would you like to make us a comment? And if I can ask you to be short, thank you.
Yes, thank you very much for the opportunity. Can you hear me?
Yes.
Thank you. Then I will be really short. I just would like to share the main results regarding the digital health literacy of the elderly, and what we found that the average level of digital health literacy is lower among them than in the general population or as the national average. And when we ask them which kind of digital tools they use, then they mostly just checking their electronic health records and searching on websites, but the other tools are really used by the elderly. And also when asking where they experience any kind of difficulties, mostly they mention that it's hard to judge the reliability of the information or judge whether the information was offered with commercial interest. So maybe this could be the point of intervention together with informing them what other tools are available and how they can it used. Thank you very much for the opportunity.
Thank you very much, Eva. I would like to thank to all our speakers and participants for this engaging and thought-provoking discussion. And with that, I will now hand the floor back to our colleagues from WHO to share key takeaways and opportunities for future engagement. Thank you very much again.
Thank you so much, Sultan, and for all the colleagues that commented and asked their questions, and for our great panelists who stayed with us and shared and responded as well to all the questions, also in the chat. Very, very nice to see the engagement. I hand over to Youngji, who, as we promised, will tell us more about how to engage in the healthy aging strategy development. Youngji.
Thank you so much, everybody, for this great, very inspiring discussions. I'm Yang Ji-Yon, the technical lead for the Aging and Health Program at WHO Europe, but also very proud to serve as the Vice President for the Healthy Aging sections of EUPHA. I think what we heard today is very clear that our current system is not fit for purpose, and managing multimorbidity requires more than just clinical solutions, and it really does require this fundamental shift in how we design our system, how policy should address the complexities inequities and the realities of the aging populations. I think that is why we are in the process of develop the WHO European strategies on aging, which is to promote health and well-being at every stage of life. And as Dr. Ivan Bachman mentioned, is to build functional abilities by addressing intrinsic capacities. And I think at the heart of these strategies is a clear message that aging is living, and too often aging is framed as a period of decline and dependency, but aging is not a problem to solve, but really a privilege, and it should be a time of purpose, connections, and contributions. So our strategies will shift this focus from managing the decline to supporting potentials, from preparing for dependencies to enabling autonomy. And I think part of this is we want to hear from you. And I have just one quick slide to share to advertise about how you could help us in shaping this strategy. And so we are co-developing this strategy together, of course, with our member states, with civil societies, with academia. And in a couple of weeks, on the 27th of May, we will host our next major consultations, this time with civil societies, non-state actors, and the youth networks, because youth of today are older persons of tomorrow, that will shape directly to the strategies. And I wanted to put this slide up for a moment so that you can register, and my colleague will also put on the chat the actual link for you to register, because it is important that you join and tell us what actions is needed. Of course, within these strategies, we have identified 4 broad areas of actions, and that's about preventions and health promotion, as we discussed today, how we transform our care system, how do we create supportive environment, and how do we address ageism. Beyond that, we are really, of course, working with our Dr. Ivan Bachman and our partners to identify actions that are needed to achieve healthy longevity. So I hope you can join us on the 27th of May. Later this year, we will, of course, also have another consultations, and this time with academics and research networks. And we will share this, of course, through our healthy aging section of the EUPHA. And so thank you so much for this really great discussion. And we look forward to seeing you on the 27th of May. Back to you, Emilia, for the closing.
Thank you. I don't want to take any more everyone's time. So just thanking everyone who was here. Thank you for sharing the tools, the knowledge. I think we get good information about how to prevent multimorbidity, but also how to manage it, because it exists in a large part of our population. So we do need to help, and we have tools available. So thank you so much to everyone for joining us, and I look forward to seeing what continues in the European Public Health Week. So Young, you would like to